Welcome everyone to another edition of Hirad EP Journal Clubs, and today we're going to talk about device, new interesting stuff, new interesting publication and devices in month of August 2022. All right, let's start. Okay, we start with three papers from Heart Rhythm. These three papers were talking about septal left bundle pacing, and after that, the last paper that we're going to review today is going to be about ICD system, the new sub-Q ICD system, and the publication in New England Journal of Medicine. Now, let's start with devices in EP and the focus today with the septal left bundle branch pacing. The first paper is the clinical outcomes of conduction system pacing compared to BIV pacing in patient requiring CRT. As you see, this is an observational study, and the purpose is to see if the BIV pacing is better or the same or less effective and good comparing to conduction system. And the conduction system has both his bundle as well as left bundle branch pacing. 477 patients were included, 219 patients had BIV pacing, 87 his bundle, and 171 patients have the left bundle branch pacing. The outcomes they looked was the primary outcome they looked was heart failure and death, and then in the secondary outcome, of course, they look at each of these separately. They follow the patient around 30 months or so, 20 months or so, around close to 3 years, and they look at the changes in the QRS, the heart failure hospitalization, the death, the ejection fraction improvement, and stuff like that. So if you look at the time to death or heart failure hospitalization here, as you see, in the patient with the conduction system pacing, which means his bundle and left bundle pacing, you have a 28.3% patients with the death or heart failure hospitalization, and it's 38.4% for BIV pacing, and there was significant difference with the p-value of 0.013, as you see here. If you get rid of the his bundle and include only left bundle branch pacing, you still have a positive results and significant results with the p-value, much better with the hazard ratio of 2.1, and as you see, 20% had the outcome of death or heart failure hospitalization versus 35%. The 35% is the kind of usual range that we see most of the trials of the CRT. If you look at these two things in separate and to understand what is a driver or what is the most likely the driver of the difference, you see our usual culprit, and that's heart failure hospitalization. So freedom from heart failure hospitalization was significantly more in the patients with conduction system pacing, and it has a ratio of 3.1, while freedom from death was not significantly different, although there was a trend favoring the conduction system pacing. And if you look at other stuff like QRS duration, you see that the BIV pacing improved QRS duration versus baseline, but the one that improved most comparing these two was the conduction system pacing. And if you include only left bundle branch pacing, you still have that significant improvement in your QRS duration. Same you can see in patient with ejection fraction, improvement in ejection fraction, also same thing. The conduction system pacing improves as well as BIV pacing, but conduction system pacing improves more than BIV pacing. Now, this is an observational study. This is not a randomized trial, but is one of the things, one of the study that hints that conduction system pacing might improve ejection fraction, quality of life, heart failure, hospitalization, QRS duration, and a lot of the benefits that we see in CRT more than CRT. And this is a beginning, and we are looking forward for the larger randomized trial to answer this important question. Okay, let's talk about the second paper. And this paper answered a very interesting question. Does patient that we have a rescue left bundle branch pacing for, those patients with a coronary venous lead failure or non-responder to BIV, these two groups, do they respond further to left bundle branch pacing? This was published in August 2022 in Heart Rhythm. As you know, 5 to 10% of the patient when we want to implant CRT, we have a difficulty to implant the CS lead. Also, we have about 30% of the patient with the CRT already have CRT in relatively okay location CS lead that they don't respond. So we have a non-responders and the group of patients with the CS lead failure that we always have a question what else we can do. Options, of course, is the implanting of the LV endocardial CRT, which is under trials, under investigations, but you need a long-term anticoagulation. There's a risk for implanting endocardial LV CRT system. And the second one that comes to the mind is to do a surgical CRT and ask the surgeons to implant epicardial leads. And as you know, that also comes with the risk of surgery. How about left bundle branch pacing, septal left bundle pacing? How about that? So in this study, they look at the 200 patients and they enroll, basically is an observational study. They implant left bundle pacing for these two problems. 156 patients had a coronary sinus lead failure and the 44 had non-responsive to the CRT situation. This was done at 16 centers. They look at the outcomes, the usual outcomes of the heart failure and death, echo outcomes, procedural data, all those kind of usual things that they look. They had 1.5% complication rate, 2 had early lead dislodgement, and 1 had pneumothorax. These implanters were very skilled, so it might be higher in the real time, in the real world. So what they notice is that if you have a patient with the indication of coronary venous lead failure, those 150 something patients, you get an improvement, significantly narrowing of your QRS. But this is more significant than the group of non-responder, although both of them respond to the septal left bundle pacing. Both have some improvement, but the improvement is more in patients with the coronary venous lead failure. Same happens in the New York Heart Association functional class, so the improvement is more in the group 1 versus group 2. Same thing with the ejection fraction. We have improvement in both groups. Actually, about 50% of the patient of non-responder, they have some good improvement in ejection fraction and decrease in the diastolic volume. But again, in these echocardiographic findings, you see that patient with the indication of CS lead failure, they benefit more. And finally, if you compare these two about how much of improvement with the outcome of death or heart failure you see significant difference between the non-responder and people that got implanted with the indication of CS lead failure. And it seems the patient are a non-responder, they might be in a more advanced stages of heart failure, they might have a sicker heart, and that's the reason nothing, including CRT, didn't respond. And it was not necessarily because the CRT was not helpful enough, because the substrate and the heart was sick. So that's very important finding, that if you have these two issues, one of the good approach might be implanting of left bundle septal left bundle pacing, which nearly half of the patient or the non-responder might benefit further, and their heart failure might be less problematic. All right, fantastic. And then we're going to go to the third paper from Heart Rhythm shortly. So hang on. So in this paper, interesting paper, is trying to help us, to guide us to identify how deep we are when we're implanting septal left bundle pacing lead. The title of the paper is Current of Injury is an Indicator of the Lead Depth and Performance During Left Bundle Branch Pacing Lead Implantation. This was published from our Chinese colleagues, and they had 513 attempts in 212 patients. And they came up with some algorithm based on how the current of injury is in their tip of the lead as well as ring of the lead, to help us to proceed if the outcomes, the output is not as what we expect. And there also is a guidance for us to when to reposition our lead. Now, if there's no current of injury, of course, we are not in the septum, and there's a high chance that we had a septal perforation. So if we look at this figure and these examples, at top and the left side we have tip electrode, and the middle part we have a ring electrode. In tip electrode, before perforation, at the EGM of the tip, when you do tip, you will see unipolar of the tip, you see that there is a significant ST elevation. There's no Q wave going on here, and it's positive ST elevation current is observed. Now, when you do a microperforation, you lose that ST elevation, and you have this Q wave formation in your EGM. And when you start to try to capture it, you are not able to capture it because you are out, or you will capture it with a lot of delay. So there's a time delay between the capture and so that's in the case of microperforation. In case of microperforation, we lose our current of injury in the tip electrode, and you might not able to capture with especially with lower threshold. Also, if you look at the same situation in the ring electrode, when you are in the ring electrode, your ST elevation exists in the ring as well, because your lead is all the way inside the myocardium, and you will see that the ST elevation of the current injuries, this amplitude is much higher than the injury amplitude that you see in the ring. But when you start to go more and more, you get this little bit more Q wave pattern again shows up in your ring as well. Your current of injury start to shrink, and you lose it, and you might not able to capture it still if it's not fully perforated and microperforated with your ring. But the further that you get out, you are not able to capture it with your ring as well. And then when you inject contrast, you see the contrast gets out of the in the tissue and goes to the cavity. So that favors that too. And when you start to go back, you see the current of injury. When you pull it back, the lead, the current of injury starts to get more and more when you're back to the tissue. So again, if I wanted to summarize this part, the current of injury, when you get closer to the perforation, you will see that the tip starts to get shrink, your ring starts to get more, and then the ratio of the tip to the ring starts to shrink. As well as that, when you lose your current of injury, you have this Q wave where you're not able to capture it in tip, or you are only able to capture it in the ring but not tip. That means you had a perforation. Now, and this is the algorithm, nice algorithm that they propose, and it can be very helpful. And basically, you have this initial measurement of left bundle capture, and if the threshold is less than 1.5, you're happy, you're good, especially if all the criteria meets, that you are in close to the left bundle and you are capturing the left bundle potential or left bundle area. If the 1.5 threshold is not achieved and is more than that, then you will see if there's if it's more than 10 volt, of course, that's very high. You need to reposition it, especially if you're past the septum, it might be perforated and you need to reposition. But if it's not that high and it's still capturing, more than 1.5 volts, then you look at the current of injury at the tip. If the current of injury is present, give it some time, 10 minutes to 20 minutes. And if it's after 10 to 20 minutes still, there's no good numbers, then you can do repositioning. But if the current of injury at the tip is not present, then you most likely have some sort of microperforation, and then you need to reposition. So if your capture threshold is more than 1.5 and you need to wait, especially if you have a current of injury present in your tip, you need to wait, and waiting 10 to 20 minutes might be all you need. So that's about it. And in this study, they also found that septal perforation was not common, and 2% of the patients had a septal perforation. They also mentioned something interesting, that if your unipolar impedance is less than 450 ohm, is basically you need to be think about the perforation. All right, thank you. Okay, let's get to the last paper of this edition, the sub-Q ICD. And this is, of course, the paper published in New England Journal of Medicine, Efficacy and Safety of an Extravascular Implantable Cardioverted Defibrillator, EVICD. And this was a prospective, non-randomized study. It was attempted in 316 patients. And this is extraventricular, basically a sub-Q ICD that you have a can, is a Medtronic can, and mid-axillary line, they implanted and tunneled the lead, and the wire basically goes here and then tunnels under the sternum close to precardial space, and it can provide few extra things. It can provide anti-tachycardia pacing as well as anti-bradycardia. If there's a pause, they can provide with some pacing here. As well, the can is not that big, so the risk of hematoma will be less, and it can provide less joules. It can terminate the tachycardia, it can defibrillate the VTVF with less joules because it is in the precardial cavity, is around the cardiac sock. And so that's the interesting thing about this substernal positioning of ICD lead. Make it very close to the precardial space and the heart, so you don't need higher energy to shock the patient out. Now, they mentioned there was no major intraprocedural complication. At 6 months, they had some issues, like in 7.3% of the patient, and they have to remove 8 of these ICDs. 4 was for infection. It was 1.3% of the total. But there was no evidence, there was no cases with mediastinitis or a lead failure, a lead infection. Now, other interesting things that they reported with this method was that at the time of implant, most of the patients had a successful, 98.7% had a successful defibrillation at time of implant, and the median joules they need was about 15 joules, while most of people required about 30 joules or less. The second interesting thing was that 8.5% have inappropriate shock, and this happened mostly because of the P-wave oversensing, because usually the lead was getting close to the right atrial appendage, and they said, they improved the method a bit, and they found a less inappropriate shock at the later time of the procedures. So they think maybe positioning can decrease inappropriate shock and oversensing of the P-wave. ATP was 70% successful. Out of 46 monomorphic VT, we were able to terminate 32 VTs, which is interesting. Other interesting fact about this study. And so, of course, this is a beginning, and this is a promising data about efficacy and safety of the implantation of extraventricular ICD implants. This might provide an option to sub-Q ICD world, and we'll see with the more trials, with more data, that how this goes, and it looks promising at this moment and might be seen for one of the options for implantation in near future. Alrighty, thank you again for this edition, and stay tuned for more. Hirad EP will come soon, and thank you very much. Take care. Bye-bye.